what responsibility is there for Mercy in helping this community? And I'm talking from jobs, from the standpoint of mental health awareness, things of that nature. What responsibility falls on the institution?
Yeah, I don't know that there's a bright line as to where that responsibility begins and ends. We frame it up in terms of being good help to our communities and trying to create some priorities out of that. So, again, I'd look back to what's economic impact and community development we can do, what's chronic disease management we can do, and what are some of the acute healthcare needs that probably we're uniquely positioned to address. So if you try and do everything, you accomplish nothing. We don't want to set out to boil the ocean, but let's set those priorities. So we do the same things all health systems do. We do a community health needs assessment. We identify those needs based on that assessment and then put health improvement plans into place. But it's all defined around what those community needs are and where we think we can have an impact. So I would say, for example, housing's been a big issue, at least as we look at this Getting Healthy Zone, what we call it. And through the efforts of our ministry, we're investing $3 million over 5 years, and it's really targeted towards individuals who they don't qualify for some of the state and federal dollars that are available for support because they make too much money. On the other hand, they don't make enough money to qualify on their own for loans to help put in a new roof or repair a foundation, things like that. So through this, which is basically a very low interest loan, like 1.5%, we're able to make those loans really through our partner, Toledo Federal Credit Union, doing that. And it's gone off to a gangbuster start. There's been a lot of interest and a lot of demand for it. And then the goal is to reinvest those payments back into expanding that over time. I mentioned our Financial Opportunity Center. Through that Financial Opportunity Center, we probably have served close to 300 people, and of those we've served, we've on average, and so I'll say pretty much across the board, we've improved credit scores, we've been able to help with tax refunds, we've been able to help with securing jobs and interviews and placement services. And so even for us, back to your question about obligation, one of our obligations is we want individuals who live and work and play in the community to work here, be part of our ministry. So we have about 175 folks from the corridor, from the Getting Healthy Zone, who work within our ministry. That's a 7% increase over last year, and it's going to be more next year. We want to continue that and make sure that our services are representative of the community that we serve. And the other thing I'll share is this, over time, we've been a long time in this community. We are an anchor institution. At different points prior to me, the conversation has come up, can we continue to have St. Vincent's be a tertiary hospital in this area? And the answer has always come back to our mission. We can't be anything other than that. We will never leave this area. This is part of our core service, part of how we identify ourselves and who we are.
With what's happening around you as far as healthcare is concerned, and there have been quotes out there, Bob. I mean, people have said, and I've pulled up reports, and I wrote down one quote: "We are massively bankrupting America." That's an overview of healthcare, and you see what happened out with St. Luke's. You see all the shedding that's happening. Maybe ProMedica got out over its skis as far as some of its projects were concerned. But what is your overview of solubility of healthcare?
Yeah, I mean, that is, I think an existential crisis that the country faces, is how do we deal with healthcare expense? And the simple way that I look at it, and there's probably a number of pathways we could go down.
Is the model flawed?
Oh yeah, I think we could all agree. I mean, in a country where we have so much division, we could probably get 100% unanimity that there need to be changes to the healthcare model. What those changes are, though, is, I think, the area of great debate. The way I tend to look at it is very simplistic. I look at things in threes because I can't keep track of four. But, at its core level, this is an oversimplification, we as a country are making choices about cost, quality, and access in healthcare. And, it's easy to have two of those things. You can have quality and access, but that comes at a high cost. But having all three of those things is really the societal and policy discussion that we as a nation need to have. How do we balance those three things and keep them in equilibrium? So there is a cost to healthcare. Obviously, we see that as an increasing portion of the GDP, and unfortunately, healthcare becomes something that people can less and less afford every day to have. Now, what are some of the solutions and what are some of the other ways to look at that we need to think about? One is through the lens of what are going to be our priorities as a nation. It's very complex. It's difficult for any one provider to unwind an entire milieu of how healthcare is offered and paid for. But I think there are some things that we can do. On one hand, we've really focused on what we call value-based healthcare, as have a lot of other health systems. But it's this idea, if you will, that, and I'll use an analogy or metaphor for it, when the bridge collapses, everybody comes in with heroic efforts to take care of the injured, to rebuild the bridge at great expense. But we don't pay a lot of attention to the study that came out 3 years beforehand that says for a fraction of the dollars we can prevent that bridge from collapsing. That's sort of one of the crises we have in healthcare today, is the heroic efforts at the time of intervention and high acuity are absolutely there. And I'll tell you, healthcare in this United States is amazing at that level. I mean, there's a reason people come from all over the world to the U.S. to get their healthcare. What we don't do so well is the investment piece on the prevention side. So there's a lot that could be done, I think, nationally in that space. We're trying to do that in our own space through accountable care organizations, a clinically integrated network, trying to create value-based contracts with our payers so that it makes sense for our physicians to think as much about the patients who don't come into the office as they do about the patients sitting across from them. Because we know when the patient's sitting across from the physician or the nurse practitioner or whoever it is, they get great care. We do an amazing job with that. This nation, healthcare providers do an amazing job with that. But we're not necessarily thinking about the people that we're not seeing. And I think that's where some of the gains can be made to keep some of those three things in balance. And I think the other piece, though, that doesn't get talked about as much is what is the value that healthcare brings to the communities that we're in. So, and I don't just mean like economic value in terms of, especially our small communities, the importance for the economy, jobs creation, income taxes in the community, things like that. But oftentimes, as a not-for-profit healthcare provider, we are the access to services that people need. And we have to look to protect that, the access to services for the health of the community, the strength of the workforce. And to your point about some of the issues that providers throughout Northwest Ohio and throughout the country are facing, we are all in this storm. As healthcare providers, I view it as we are in a storm and the ocean is roiling and the rain is coming and the wind is blowing. Some of us will survive that storm better than others. And I think frankly it has something to do with how strong of a boat you're in, right? I'd rather be in the ocean liner than the tugboat in terms of all being in the same storm. But there will, in my opinion, be definitely a shakeout that goes on through this time period through no fault of bad health care being provided or something like that. Some of the issues that we look at today is more than half the hospitals in the country have a negative operating margin. So that's a pretty broad stroke to talk about. And contrast that to the fact that just 2 weeks ago, Modern Healthcare reported that Elevance, which is basically manages Blue Cross and Blue Shield plans for 14 states, reported a 16% increase year over year in their operating income, which was a massive number to begin with. So what you have is a situation where the folks who are processing the claims are securing the resources and having financially boon years, and the folks providing the services to patients day in and day out are at negative or break-even operating margins. So I think there's some rebalancing that we need to think about in this phase, because none of us want to have the impact of the lack of access that could happen at the end of this storm.
And when I asked about the model and if it needs to be retooled, we just had Mercy College of Ohio graduating its nurses, obviously, just within the last week. And we interviewed one young lady who said, this is a call, this is a passion. You don't come into this to make money. With that being said, when I talk about restructuring of the model, you talk about bringing in, or articles that have been published talking about bringing in surgeons from out of city, paying them lump sums. And is that balance screwed up as far as the payment scale? And those who you guys have seen shed, as far as employees are concerned through the pandemic, the burnout rate, all of that. Does that play into this? Does that Does getting away from the pandemic force you guys into a new mentality of how we do things?
Well, I think I would say it this way. I mean, our associates, the people who provide the care or support the people providing the care, have always been, one of our priorities. I think post-pandemic, it's priority 1, 2, and 3. And so it's not that we've ever neglected it, but it's become an acute issue. And one of the things we need to do is really think more deeply and more strategically about how we create an environment that people want to work in, and develop a pipeline that starts not when they graduate from a nursing program or another allied health profession, but starts orienting them to it when they're in middle school or high school. Junior Achievement's been a great partner for us in that space, really connecting employers to students, but also creating exposure opportunities to see what a career in healthcare might look like. And by the way, it's not just clinical. I mean, every job you have in a large city, we probably have in a healthcare system, whether it's HR, marketing, or finance, or boiler plant operators, whatever the case may be. But then once we've kind of exposed people to the opportunities within healthcare and the broadness of it, that we also look at how do we support them in terms of making sure that they don't have to come out of pocket for it. So I think one of the big changes we've seen, one of the things we're doing, and I know others are doing, is you can enroll in our what we call our Guild program, and it really provides a pathway. So if you're a housekeeper and you aspire to do something to become a nurse, we'll pay for that education with just really minimal hours working to be able to support the idea that we'll pay for the entire education. So if you're one of 6 disciplines, if your interest is in nursing, RT, or some of the other disciplines, we'll not only reimburse you, but we'll pay the education so you don't come out of pocket really for about an 18-month investment in time at the end of it, which is all to say we're just trying to eliminate the friction of getting into healthcare. And then when we get folks into healthcare, and I'll just continue to use nursing as an example because obviously that's a big part of the employment population, is how do we create an environment where the tenured staff doesn't eat their young, so to speak. They should know these things, but they don't. They're new, and not only that, but they probably got their education during the pandemic when the clinical experiences were less robust. So creating blue ribbon units so we can have an environment that mentors nurses in this case. And then we've also done, as an example, and I just give this as an example of the idea that we need to get people to the top of scope to address some of our labor issues. So how is it we can help a family practice physician maybe address some of the issues that a specialist was dealing with before, a nurse practitioner deal with some of the issues a family medicine doc was dealing with before, an RN maybe take on some of the NP issues. You get the point. That we use their time where it's most valuable. So over at St. Charles, we've introduced a program called CTA, or Care Through Associates, where we basically give nurses a scribe. Because you've seen the studies, an amazing amount of a nurse's time is spent on non-clinical, not patient-facing responsibilities, and it doesn't require an RN to do it. So give them a scribe, take those things off that list so they get to do the things that they're the best at and that they love doing, and it creates a better environment for them to want to stay.
In turn, maybe lessens burnout.
Hopefully lessens
Plain and
burnout.
simple, yeah.
Yeah. And the scary thing is, I saw a study 2 weeks ago. We lost 100,000 nurses during COVID. The study said by 2027, 800,000 nurses plan to retire or leave the profession. I mean, you put that and you layer it on top of the baby boom bubble that we're facing. I mean, we have to get better about how we make ourselves appealing to people who want to consider a career in healthcare. And I think the biggest point for that for us that we probably haven't talked about enough is we get to connect people with our mission and our ministry. And what other profession can you go and have such a personal impact on an individual's life day in and day out? I think we need to talk about that more and then create a safe environment for people to grow in that.